Yeah. Hi, everyone. Welcome back to another episode of Quick Care Bites. For those of you new to us, this is a podcast where we discuss all things critical care. And today's episode is another one of our Ask the Expert series, where we interview experts in the field of critical care about different topics in the ICU. And today, it gives me great pleasure to invite Dr. Pipetius Kwa to speak to us on massive hemoptysis. Dr. Pip is a consultant pulmonologist and intensivist at Woodlands Health Campus. He obtained his European Diploma in Intensive Care in 2022. He has an avid passion for medical education, having recently won the NHG Teaching Award for Senior Doctors and serves as the Associate Program Director for Internal Medicine in the Woodlands Health. He's the clinical lecturer for the Lee Kong Chian School of Medicine and Yong Lulin School of Medicine. His clinical interests are in interventional pulmonology, endobronchial ultrasound, and medical thoracoscopy. When he's not out there saving lives and inspiring the next generation, he lifts steel to engage in sarcomere growth and stimulates the auditory sensations through the tickling of the ivories of a piano. It gives me great pleasure. Thank you for joining us, Dr. Pip.
Hey, thanks, Tom, for the very extensive welcome. And thanks for having me for today's podcast.
Yeah, it's great to have you here. Without further ado, can you tell us a bit more about Haemoptysis? Yeah. So what is massive haemoptysis? How do we define it?
Yeah, so massive hemoptysis is just one of those things you hope you don't have to see in your time running the ICU. Uh, Hemoptysis in general is something which is uh, quite scary for most people who encounter it for the first time. And yet, strangely enough, we don't actually have a fixed definition for what is massive and what is non-massive hemoptysis. Essentially, what we are trying to look for is we are concerned about any blood volume that can potentially cause asphyxiation. And we know the anatomical dead space in a typical adult is about 150 mils. Therefore, if you see some definitions will tell you massive hemoptysis is about 150 mils over 24 hours. Certainly, any hemoptysis which causes respiratory failure or hypotension, we consider it to be life-threatening. Uh, What probably is quite important is we don't want to just focus on the volume. Sometimes the volume itself can be quite hard to quantify, but the characteristics of the bleeding are also important. For example, if you note that it is fresh blood and the amount of blood is increasing with each episode that a patient coughs, that is certainly very worrying. Also, if the patient is becoming drowsy and is unable to maintain the airway, that is something which we'll be very concerned about.
Right. Okay. Thanks for that. And can you tell us a little bit more? There are many, many different causes for hemoptysis. Like, what are some of the things we need to consider when we encounter a patient who's coughing out lots of blood?
Yeah, so I think there are different ways that we can categorize the causes of hemoptysis. I think in our local context in Singapore, the things which are most common tend to be tuberculosis, lung cancer, or bronchiectasis, as well as complications from TB, such as if the patient develops a mycetoma. Certainly, if you see there's an extensive list of causes possible, and we can either broadly divide it into cardiac causes, iatrogenic causes, infectious causes due to drugs, due to pulmonary vascular diseases, other immunological or rheumatological causes, as well as vascular diseases. Uh, the list is quite extensive. We can also consider different ways of categorizing it, such as by anatomical structures, either airway disease, parenchymal disease, or vascular disease. So whatever way you choose to remember it, I think it's important to maintain a wide list of differentials, and yet also focus on the most common things that would cause massive hemoptysis.
All right. Um, how does hemoptysis actually happen? What is the physiology behind what happens in the lungs?
Yeah, so we need to remember that the lung is perfused with two blood supplies. The first is the pulmonary circulation, which contributes about 5 to 10%. It is a low pressure system, but we do have to remember the entire cardiac output will course through the pulmonary arterial circulation. With regards to massive hemoptysis, we're really focused on the bronchial circulation. And the bronchial circulation is subject to high systemic pressures. It arises from T5 to T6 in the aorta, and it provides the nutritive supply to the airways and the mediastinum. And the bronchial circulation and the bronchial vasculature is really what we are focused on in patients with massive hemoptysis.
Okay. So for gastro patients that come in coughing out lots of blood, like the first thing that our gastro friends would go in with shove a camera in, they'll look and hunt it down. Where's the bleed? What about us? Like for people who are coughing up blood, what is the initial assessment for the patient? Do we go straight in with a bronchoscopy, try to hunt where the bleed is, or is there a different approach?
Yeah, so I think as with all cases, we want to make sure we stabilize the patient first. Certainly, the airway breathing and circulation is important. And if the patient is able to give a history, we do want to be able to differentiate between upper airway causes of bleeding versus whether the bleeding is truly coming from a pulmonary source or whether it is a GI source. We also do want to look for underlying contributors to bleeding, such as any drugs which the patient may be on, like aspirin, Plavix, or any of the anticoagulants such as warfarin or rivaroxaban, etc. And really what we want to do is to have an idea of what the possible causes of hemoptysis could be. For example, if the patient is known to be a heavy smoker with weight loss, and on examination we see things like cervical lymphadenopathy, clubbing, SPCO, then we would think that lung cancer is more likely. Certainly, if the patient has positive contact history or history of night sweats or TB contacts, then we would consider tuberculosis as a more likely cause. The management really would not to be to shove a scope in at the immediate juncture. What we want to do is to try to have an idea of where the bleeding is coming from first. If we do know which side the patient is bleeding from, for example, the right or the left side, we would lie the patient with the bleeding side down. And then subsequently, we'll try to get some form of imaging in order for us to know exactly which side bleeding is coming from.
Okay. So you mentioned trying to identify the bleed. So how do we then localize the bleed?
Yeah, so most of the time we would need some form of thoracic imaging. And in this case, we would often start with a CT thoracic angiogram. Certainly, if you remember when we were discussing earlier, the bleeding really is most of the time related to bronchial circulation. And by doing a thoracic angiogram, we can identify the site and the cause of the bleeding. We can also look at the cause of both the bronchial and non-bronchial collateral supply. And most of the time, we will be able to find the cause of the bleeding and localize it to one side of the lung. Having said that, there are some situations where doing a bronchoscopy is important. For example, if the patient on CT imaging has bronchiectasis and we find that the bronchiectasis is bilateral, certainly what we want to do is to find out really, is it bleeding from the right or the left side? If not, it might be challenging when the interventional radiologist has to go in with a BAE to try to cannulate both sides to find the source of bleeding. And it might be quite tricky to embolize in such a situation. So first step really is to get a CT. And if from the CT, we can already identify the bleeding, then we can proceed to manage accordingly. If, however, there's a situation where there is, for example, bilateral disease and we're not quite sure, then a bronchoscope is probably going to be useful. Certainly, if we combine both CT and bronchoscopy, most of the time we will be able to find out where the bleeding is coming from.
Right. Are there certain situations that you would not do a CT thoracic angio? Let's say a CT thorax, would that suffice, or would there be any value in doing a CT pulmonary angiogram instead?
Yeah, I think it's important to remember what the differentials are and what are the things we're looking for. The main difference between CT thorax versus a thoracic angiogram and a pulmonary angiogram really is the application of contrast and the phase in which the contrast is given to highlight the structures that we want to see. So for example, we do a conventional CT thorax with contrast because we want to look at structures like lymph nodes, or we want to see contrast uptake to delineate soft tissues. Then certainly, for example, if you have a patient with lung cancer, you want to look for presence of a primary tumor with lymph node involvement, then you should do a CT thorax. For CT pulmonary angiogram is specifically when we are looking for pulmonary embolisms. In a case where the patient has a suspicion of PE with risk factors, or you have already picked up a DVT by bedside, then certainly you should be doing a CT pulmonary angiogram. But by and large, for patients with massive hemoptysis, the imaging of choice is the thoracic angiogram, especially if you're looking to do the next step of treatment, such as bronchial artery embolization.
Right. Okay. So for these patients that come in with massive hemoptysis, when do we need to intubate them?
Yeah, Dom, that's a great question. And I think there are some variations in practice between physicians. In fact, on a personal level, I try very hard not to intubate these patients because if you remember, your ETT size that you can put in is maybe a size 8 or 8.5 ETT, whereas the patient's native trachea size is going to be anywhere between 15 to 25 millimeters. If the patient is able to maintain an effective cough and can expectorate the hemoptysis out, then it may actually be preferable to leave them on their native airway to allow them to continue to cough out the blood as it accumulates. If you've ever experienced it before, it can be quite a struggle when you put in a size 8 ETT for the patient, and then continuously for the next couple of hours, you're just struggling to try to suction out all the blood through this small ETT. The HME filter will get continuously blocked as the patient is coughing. So that in itself may actually pose more of a struggle. So in such cases, I always caution against rushing to intubate such patients. Certainly, there are clear-cut indications where we should intubate. Firstly, if the patient can't cough out the blood effectively, or if they are drowsy and unable to protect their airway, if there is worsening respiratory compromise and they are unable to effectively oxygenate or ventilate, or certainly if the patient is going into respiratory or cardiac arrest, then you should intubate these patients. In all the other cases, intubation is not a prerequisite to you performing the other interventions like bronchial artery embolization, for example.
Right. Okay. And in terms of the situation in situations that we do have to intubate patients, what are some of the considerations that you would need to think about when doing so?
Yeah, so I think the first point is that this is going to be a difficult airway situation. Certainly, the most experienced operator should be performing the intubation, and you should be prepared with equipment such as a video laryngoscope, and advanced equipment should be available as well. You certainly do want one, if not two, preferably working suction machines, so that you can both do suctioning with a large bore Yenker suction and also inline suctioning through the ETT when you need to. You should also be trying to put in as large a diameter of an ETT as possible. Certainly, this is to allow the patient to be able to continuously cough out the blood. And if you have a view of doing a bronchoscopy, you will need as big a ETT to allow you to maneuver the bronchoscope inside smoothly. There are also certain other considerations about putting in the ETT. For example, if the patient is having massive hemoptysis from the right side of the lung, sometimes we can also consider selectively intubating the left side or vice versa in order for us to continue to effectively ventilate the patient. And by doing so, also hopefully create a tamponade effect to stop any spillage of blood over to the contralateral side. I often caution about putting in dual lumen ETTs. Certainly, not everyone is familiar with putting in a dual lumen ETT, and we have to remember that each individual lumen is much smaller, and it does not allow for us to introduce a bronchoscope subsequently as well. Given the technical difficulties and the challenges of correctly positioning a double lumen ETT, by and large, for myself on a personal level, most of the cases of massive hemoptysis, I often opt to just insert as big an ETT as I possibly can.
Okay. So we've talked about assessing, we've talked about when to intubate. You briefly mentioned BAE in the setting of the CT thoracic angiogram. How would we manage someone who comes in with massive hemoptysis?
Yeah. So, as mentioned, I think right sighting of the patient is important. Certainly, the patient will need to come into the ICU, and we will need to ensure that the patient has adequate access. Get your two large bore IV cannulas in, do your blood tests with your coagulation and group and cross match. Make sure you reverse any causes for bleeding. For example, if the patient is on uh, warfarin, certainly you need to think about reversal for that. Or if the patient has recently been given heparin, then you might need to give protamine, so on and so forth. There are also other medications we can give, such as tranexamic acid, which can either be given by the nebulized or intravenous routes. And most of the time, we would be thinking about doing a bronchial artery embolization if the patient is having ongoing large volumes of hemoptysis. And of course, there are other options such as flexible bronchoscopy, rigid bronchoscopy, and as a last resort, in some cases, we may need to do surgery.
Okay. Could you tell me a bit more about TXA? Because I've seen some people give like oral, some people give IV, some people give nebulized TXA. What's the evidence behind that? And when do we give it?
Yeah, so in such cases, really, I don't think anyone should really be giving oral tranexamic acid to these patients. Most of these patients, we will be giving them nil by mouth anyway. Um, by and large, for these patients, we either give nebulized tranexamic acid or intravenous tranexamic acid. So in this paper from CHEST in 2020, you can see there's a summary of different interventions in the management of hemoptysis. Certainly, if you look at the IV TXA trial, in patients with submassive hemoptysis, they were randomized to either IV TXA or to placebo, and the TXA group had a decrease in hemoptysis by day 2 based on the visual analog scale. However, it's important to remember that in this group of patients, it actually excluded any patients with massive hemoptysis. The same goes for patients on nebulized tranexamic acid. They looked at patients compared to placebo after 24 hours of hemoptysis, that the TXA group was more likely to have a decrease in the volume of blood and less likely to need any interventional bronchoscopy or BAE. Yeah, so I think by and large, most of these patients, practically what we do is we give them IV TXA at a dose of 1 gram Q8 hourly to start with. But it's important to remember, because the trials did not include the patients with massive hemoptysis, that we should always be thinking about the next step of management for them.
Okay. Would you give both nebulized and IV?
No, I think it's just about choosing one. Yeah,
Okay.
because if you give one and the patient is still bleeding, then you should think that whatever you're doing is not working and we need to move on to the next step of treatment.
All right. So tell us a bit more about bronchial artery embolization. How effective is it? If we encounter someone with massive hemoptysis, intubated, and has gone through a BAE, how long do we need to wait for before we can consider safely extubating the patient?
Yeah, so I think there was a systematic review by Panda et al. That shows that success rate of BAE is actually really good. It's between 70 to 99%. We do have to remember that the recurrence rate of bleeding is high in this group and is estimated to be up to 58% in 30 days. And there are certain risk factors for recurrence also, specifically if your patient has an aspergilloma or the bleeding is due to tuberculosis or bronchiectasis, then they are at higher risk of recurrence. BAE itself is also quite good because it's a minimally invasive procedure with some low risk of spinal cord ischemia, pulmonary infarction, bleeding, groin hematoma, or complications of stroke or myocardial infarction. There are some cases where bronchial artery embolization is not useful. For example, if you've got tuberculosis and the patient has got a Rasmussen aneurysm, because this is not arising from the bronchial circulation.
Okay. What about the interventional procedures like bronchoscopy, blockers?
Yeah, so when we talk about flexible bronchoscopy, really is to try to lateralize where the bleeding is coming from. As I alluded to earlier, if you've got a patient with bilateral disease on the CT and you're not quite sure where the bleeding is coming from, then bronchoscopy may be very useful to tell you if it's from the right or the left side. There are certain things we can do during bronchoscopy, especially topical administration of ice cold saline, diluted adrenaline, or tranexamic acid. There are also things that can be done, like using a cryoprobe. We can perform clot extraction to clear the airways, and we can also place a bronchial blocker as part of the bronchoscopy. Yeah. So a little bit about bronchial blockers. There are a couple out there in the market. The one that I have in my center is the one by Cook Medical, the ANT bronchial blocker, which we can place through the ETT with the use of a bronchoscope. And when we put it in a bronchoscope, the advantage is it allows us to have direct visualization of where the blocker is going to be placed before we inflate it. For example, in the picture in the image, you can see that the bronchial blocker has been placed into the right main stem, and therefore you can occlude the right side where the bleeding is coming from. Again, a bronchial blocker is something which does require a little bit of training to be used. It is thankfully not actually a very complicated device. If you see, there are different ways of fitting it. For example, in the picture on the top right-hand corner, you do need this ETT adapter if you want to place the bronchial blocker through a separate side channel, which you can certainly do. Some operators actually prefer to place both together through the same channel. And there are also other operators that place the bronchial blocker outside of the ETT. And I think it's important to note that there are many different techniques which can be performed in placing bronchial blockers, and it's a matter of whichever one you're most familiar with.
Okay. When would you opt for a rigid bronchoscopy then? We talked about flexible bronchoscopy. What are some of the considerations you need to think about when we are thinking about rigid bronchs instead of flexi bronchs?
Yeah, so the main utility of rigid bronch is that it allows us to isolate either of the main stem bronchus, and at the same time, you can ventilate the patient. I think the first point to remember is that you do need to have the expertise available in your center when you're looking for such an option. Certainly, large blood clots can be removed. We can also do flexible bronchoscopy through a rigid bronch. If you want to do procedures such as cryo removal of the blood clots. The large channel of the rigid bronch also allows us to accommodate many different instruments. And certainly in the cases where if the bleeding is coming from a tumor within the central airway, then there are extra procedures that can be performed, such as argon plasma coagulation, or ND-YAG laser therapy, or electrocautery, or even direct mechanical debulking and coring out of the tumor. And most of the time, after a large tumor has been removed, in order to maintain airway patency, an airway stent can also be placed at the same setting. So rigid bronchoscopy can be a very useful tool, especially if there are cases of malignant central airway disease, but there is expertise that is required for this, not also forgetting that the anesthetist has an important role to play in helping to maintain jet ventilation for these patients during the procedure.
Right, right. Okay. Then what about surgery then? The last resort, right?
Yeah, and I must say that um, over the last 10 years, I haven't seen a single case requiring surgical intervention already. We do know there are cases where surgery may be required, but most of these cases are usually effectively managed with bronchial artery embolization. And we have to remember that bronchial artery embolization can be done more than once, right? So most of the time, through a combination of both bronchial artery embolization uh, and or bronchoscopic interventions, we are able to control the bleeding. But there are some cases where you have just refractory hemoptysis, and that's been described in several case reports in the literature, for example, from aspergillomas or lung abscesses or any form of chest trauma or even iatrogenic pulmonary artery ruptures. Then in such cases, uh, certainly surgery will have to be considered. Also, if there have been trials of intervention with BAE or bronchoscopic control and these have failed, and the patient is still unstable with ongoing hemoptysis, then we need to resort to surgery.
Okay. So thank you so much for speaking to us. I think we've learned a lot about massive hemoptysis, how to manage that, how to recognize it, and the kind of modalities that we have, both conservative and interventional management options that we have. Yeah, thank you so much for speaking to us, and yeah.
It's my pleasure, Dom. Thanks so much for having me. Hope you guys have enjoyed the session.